welcome back to the deep dive. But listen, today isn't about casual listening. If you are commuting or at the gym or washing dishes, I want you to shift your mindset.
Okay.
Imagine the lights in the studio have dimmed. We've got the textbooks stacked high on the table. We're talking Miller's Anesthesia 10th edition, Morgan and Mikhail, Stolting. We are in full-on exam mode.
That is exactly right. We aren't just browsing today. We are simulating a high-intensity coaching session.
Right.
Specifically for a postgraduate student who's preparing for their MD anesthesiology exams. And we're really thinking about someone facing the rigor of the Gujarat University final exams.
So to our listener, right now, you are the candidate. You are sitting across the table from us. We are going to tackle a topic that seems, well, it seems dry on the surface.
It really does.
Maybe even a bit administrative, but it's actually a minefield, both literally and metaphorically, for the anesthesiologist. We are talking about occupational hazards in anesthesia.
It's a classic topic, and it is a trap. It really is.
A trap. How so?
It appears as a 20-mark theory question. It shows up in short notes, and it is a favorite for examiners in the Viva Voce.
Ah, okay.
Because it tests whether you are just a technician pushing drugs or if you're a true consultant who understands the entire environment you work in.
And we have pulled the data strictly from the gold standards for this. We are looking at the chapters in Miller, the tables in Morgan, and this specific DNB and university question bank patterns. Our mission is to take this massive, sprawling topic and structure it. Structure it so you can write that answer sheet and hit every single high-yield point.
Structure is everything. I can't stress that enough. The examiner is looking for a consultant's mind. If you ramble, you lose marks. It's that simple.
So what's the game plan?
We're going to break this down logically. We'll start with the introduction and exam framing, then the classification, which is absolutely non-negotiable. Then we'll hit the specific hazards.
And I see we're focusing heavily on gases, radiation, and biology there.
Yes, the big three. Then we move to health effects, prevention, and finally, the bit everyone forgets, but is critical, the medico-legal aspect.
Okay, let's unpack this. Part A, introduction and exam framing. If I am the student and I turn over that exam paper and see, discuss occupational hazards in anesthesia, how do I start? Do I just jump in and list the risks?
No, absolutely not. You start with a definition that establishes the scope of your answer.
Okay.
You define occupational hazards as the specific health risks associated with the unique environment of the operating theater, the ICU, and, increasingly, non-operating room anesthesia or NORA locations.
So you're defining the where as much as the what.
Exactly. You need to establish why we are at such high risk.
Right, because it's not just about being a doctor in a hospital.
Yeah.
It's about being in that room.
Precisely.
Yeah.
Miller makes a very specific point about this. Anesthesia providers spend more time in the operating theater than any other medical specialty. Think about it.
That's a powerful statement.
The surgeon comes in, operates, washes out, and leaves. We are there for induction. We are there for emergence. We are the residents of the OT. Everyone else is just a visitor.
So our exposure time is just orders of magnitude higher.
And that room is a confined space. It's filled with chemical vapors from waste gases, ionizing radiation from C-arms, infectious agents from patients, high-voltage electrical equipment. It's a perfect storm.
It's basically a hazardous waste site that we treat like an office.
That is a very vivid and a very accurate way to put it. Yes.
And for that introduction, what else should I mention?
You want to mention that these risks are often invisible. That's a key word.
Invisible?
You cannot see radiation. You often cannot smell waste gases until they are at toxic levels. And you certainly cannot see the psychological stress accumulating until it's far too late.
You mentioned the concept of a high reliability organization, or HRO, in our prep notes. Is that something worth dropping into the intro, or is that too much?
No, drop it in, absolutely. It distinguishes a mediocre answer from a top-tier one.
How so?
Anesthesiology has really pioneered the high reliability organization concept in medicine. It's borrowed from fields like aviation or nuclear power.
Okay.
It means we operate in these complex, hazardous environments, but we maintain incredible, or they will hand you a lead apron and ask about lead equivalents or how you should store this properly. They want to see you can apply the knowledge.
Got it. Okay, that frames it perfectly. So moving to Part B, classification, you said this is absolutely essential for the theory paper.
It is the skeleton of your answer.
Yep.
I can't be more clear about this. If you don't classify, you look disorganized, and the examiner has already decided you're a B- student.
So it's the first impression.
It is. I want you to memorize these headers. If you just write these down first on your answer sheet, you've already created the structure for a passing answer.
Okay, hit me. What are the main categories? The big buckets.
We can divide them into 6 main buckets. 1, physical hazards. This is your classic stuff. Ionizing radiation, non-ionizing radiation, like lasers, electricity, fire, noise, even temperature.
Okay, physical, number 1.
2, chemical hazards. This is our bread and butter. Waste anesthetic gases, we call them WAGs for short, and things like chemical disinfectants, glutaraldehyde, latex allergens, bone cement.
Right, the stuff we handle.
Yes. 3 is biological hazards. This is huge. Bloodborne pathogens like HIV, hepatitis B and C, and of course, airborne pathogens, TB, influenza, and obviously COVID-19.
Physical, chemical, biological. Got it. What's 4?
4 is psychological hazards. And listen, this is the one students often forget, or they just tack it on at the end as an afterthought.
And that's a mistake.
A huge mistake. Examiners are specifically looking for this now. It shows you're a modern, compassionate physician. So this includes stress, burnout, and very specifically, substance use disorder.
We are definitely going to do a deep dive into that later. That's a heavy but critical topic.
We must. 5 is ergonomic hazards. This is about your body. Musculoskeletal injuries from lifting patients, static posture, intubating in awkward positions.
The aches and pains of the job.
The ones that shorten careers. And finally, number 6, some people merge this, but I like to keep it separate for emphasis, is radiation hazards.
Wait, didn't you put radiation under physical?
I did, and it belongs there. But sometimes, because of its importance and specific regulations, it's pulled out as its own category. For an exam answer, you can list it under physical, but give it its own detailed subheading.
So physical, chemical, biological, psychological, and ergonomic are the core 5.
If you list those 5, you have a solid, unimpeachable framework.
Perfect. That's the map. Now let's put some meat on the bones. Part C, specific occupational hazards. Let's start with what the outline calls exam goal, exposure to anesthetic gases.
This is the core of the anesthesia's specialty hazard profile. No other doctor deals with this in the same way. The key concept here is waste anesthetic gases, or WAGs.
Right.
These are the small but chronic amounts of volatile anesthetic agents, your sevoflurane, isoflurane, desflurane, and nitrous oxide, that leak into the ambient air of the OT.
And where are they coming from? I mean, is it just the patient breathing it out at the end of the case?
That's one source, yes, especially in recovery. But for the exam, you need to list the equipment and technique sources. Leakage from the anesthesia machine itself, either the high-pressure system or the low-pressure system.
So you need to do your machine check properly?
The negative pressure leak check is vital, but honestly, the biggest culprit is usually the anesthetist's own technique. A poorly fitting face mask during a gaseous induction is a massive, massive source.
So when you're struggling to get that seal on a wiggling child, and the gas is flowing at 8 liters a minute?
You're basically fumigating yourself and everyone else in the room.
Okay.
Or using an uncuffed endotracheal tube in pediatrics, which creates a continuous leak. Or, and this is a classic, Viva trap, flushing the circuit into the room at the end of the case to wash it out quickly.
Don't do that.
Never, ever do that. You are taking a high concentration of gas and blasting it directly into your own breathing zone.
I read this fascinating and kind of scary stat in the source material about the smell test.
Yes. This is a crucial number to quote. If you can smell the volatile agent in the OT, the concentration is likely above 30 parts per million, 30 ppm.
Okay, and just to calibrate us, what's the actual safe limit?
That is the kicker. The safe limit, according to NOH, that's the National Institute for Occupational Safety and Health in the U.S., and we use their standards as the benchmark, is much, much lower.
Oh.
For halogenated agents like sevoflurane or isoflurane, if you're using them alone, the limit is 2 parts per million.
2. And you can't even smell it until 30.
Exactly. So if you trust your nose, you are already being exposed to at least 15 times the recommended limit. It's a completely useless safety mechanism.
And what if you're using nitrous oxide as well?
If you are using nitrous oxide, the limit for the halogenated agent drops even further to 0.5 ppm.
A quarter of what it was. Why?
Because it's a combined insult. The toxicities can be additive. And the limit for nitrous oxide itself is 25 ppm.
Okay, so I need to memorize those 3 numbers for the exam.
You absolutely do. 2 ppm for volatiles alone, 0.5 ppm if mixed with N2O, and 25 ppm for N2O. Write them down.
And speaking of nitrous oxide, there was an interesting point about its atmospheric lifetime. It's not a direct health hazard, but
it shows you've read beyond the basics. Yes, N2O has an atmospheric lifetime of about 114 years. It's a potent greenhouse gas.
Wow.
Mentioning it shows you're aware of the broader global impact of our specialty. It adds a layer of sophistication to your answer.
Okay, so we have these invisible, odorless, at safe levels gas clouds. How do we get rid of them? This brings us to scavenging, right?
Scavenging is the single most important engineering control. Without a functional scavenging system, nitrous oxide levels in an OT can easily hit 3,000 ppm.
3,000 versus a limit of 25.
Yes. With a good system, it stays below 25. So for the exam, you can't just say use scavenging. You need to know the components of the scavenging system.
I can visualize the diagram from the textbook.
You need to be able to draw the diagram. There are 4 or sometimes 5 key parts.
Let's walk through them.
1. The gas collecting assembly. This is usually a shroud around the APL valve or the ventilator spill valve that captures the waste gas.
Okay.
2. The transfer tubing. This is the wide bore tubing that carries the gas away from the machine.
Right.
3. The scavenging interface. This is the most important part from a safety perspective. It's the brain of the system.
And then 4 is the disposal line.
4 is the disposal line, which dumps the gas outside the hospital, usually through a dedicated vent or into the main vacuum system.
Okay, can we pause on the interface? I remember there's a critical distinction between active and passive systems, and it all comes down to the interface.
Yes, absolutely. An active scavenging system uses a vacuum or a fan to actively suck the gas away.
Right.
A passive system relies on the positive pressure of the gas itself to push it out through a pipe, usually leading to a vent on the wall.
Active sounds more effective.
It generally is, but it requires a much more complex interface. And this is a huge safety point.
Why is the interface so complex for an active system?
Because if you hook a powerful vacuum line directly to the patient's breathing circuit, what do you think will happen?
You'll suck all the air out of their lungs.
You will cause barotrauma, negative pressure, pulmonary edema. It can be fatal. So the interface needs relief valves.
To protect the patient from the safety device.
Exactly. It needs a negative pressure relief valve to pull in room air if the suction is too high, and it needs a positive pressure relief valve to let gas out if the suction line gets blocked or kinked.
That is a critical safety point.
Yeah.
Okay, let's pivot from gases to the second big specific hazard, radiation.
Very high yield, and increasingly so. We are spending more and more time in the cath lab, in ortho suites doing spine cases, in pain clinics, and in hybrid OTs.
And we are being exposed to ionizing radiation from X-rays and fluoroscopy.
Constantly.
And the main source isn't the machine itself beaming at us, right? It's not the direct beam.
Correct. Unless you are very foolish and put your hand directly in the beam to, say, inject something, the primary source of exposure to the anesthesiologist is scatter radiation. The beam hits the patient, and the X-rays bounce off the patient's tissues in all directions, like light off a disco ball. That scatter is what hits us at the head of the bed.
So given that, how do we protect ourselves?
The 3 pillars of radiation safety: time, distance, and shielding.
And you mentioned distance is maybe the most important.
It is the most effective and the cheapest. And there is a specific physical law you absolutely need to quote in your exam: the inverse square law.
I remember this from physics class.
Yeah.
Intensity is inversely proportional to the square of the distance.
Exactly. So if you step back from being 1 meter away from the source to 2 meters away, you don't just cut your exposure in half, you reduce it to 1/4.
That's a huge reduction for just taking a few steps back.
It is massive. The source material says that standing 6 feet away, which is roughly 2 meters, is equivalent in protection to wearing 2.5 millimeters of lead.
Wow.
So the practical advice is, if you don't need to be right next to the patient during the X-ray shoot, take 2 big steps back.
And if you can't step back, if you're managing the airway during a critical moment,
then you need shielding. That's your lead apron. Standard aprons usually have 0.5 millimeter lead equivalents. But don't just stop at the apron.
what else?
You need a thyroid shield because the thyroid is very radiosensitive, and you need leaded glasses.
Why the glasses specifically?
Miller is very clear on this. The lens of the eye is particularly sensitive to radiation-induced cataracts.
Specifically, posterior subcapsular cataracts, right? That's the buzzword.
Precisely. That is the exam phrase you need to use: posterior subcapsular cataracts. The International Commission on Radiological Protection, the ICRP, has actually lowered the recommended annual dose limit for the lens of the eye recently because this risk was historically underestimated.
Okay, now let's distinguish this ionizing radiation from lasers, which are non-ionizing.
Correct. It's a different type of physics and a different type of hazard. Lasers don't cause ionization or DNA damage in the same way X-rays do. They cause thermal damage. They burn things.
So the big risk is to the eyes.
Retinal burns are the primary risk, and you need wavelength-specific goggles. This is a key point. You cannot just wear any dark sunglasses.
They have to match the laser.
They must be rated for the specific wavelength of the laser being used, CO2, ND.YAG, KTP. Each requires a different filter with a specific optical density.
And in the airway, the risk is not just to the patient's tissue, but
Fire. A laser beam hitting a standard PVC endotracheal tube is like putting a match to gasoline, especially in an oxygen-rich environment. Laser tube ignition.
we'll touch on the fire triad later, but the key is using a special tube.
A laser-resistant tube, and you usually fill the cuff with saline, often tinted with methylene blue.
Okay, and what's this laser plume I've read about? The smoke.
Whoa, surgical smoke. When the laser vaporizes tissue, it creates a plume. And that plume isn't just steam. It contains toxic compounds, benzene, hydrogen cyanide, and alarmingly, it can contain viable viral DNA.
You're kidding.
No. If you are doing a procedure on a patient with laryngeal papillomas caused by HPV, that plume can theoretically transmit the virus to your own airway if you inhale it.
That is genuinely terrifying.
Which is why you need high filtration masks and dedicated smoke evacuators for these cases.
Okay, moving from invisible smoke to very visible sharps, biological hazards. Part C, Section 5.
This is the daily grind. The source from Wiley mentions a statistic that I think it's approximately 36.7% of anesthesiologists reported a needle stick injury in a 12-month period.
Over 1/3 of us.
Ew.
Every single year. That's an astonishingly high number.
It is, and it tells you that despite all our training, these things happen. And not all needles are created equal in terms of risk, right?
Explain that.
A hollow bore needle like an IV cannula or a hypodermic needle used for an injection is much more dangerous than a solid suture needle.
Why?
It carries a larger volume of blood inside the needle itself and therefore a much higher viral load if the patient is infected.
Okay, so what are the big 3 viruses we're worried about?
Hepatitis B, hepatitis C, and HIV. And you absolutely need to know the transmission rates for the exam. This is the rule of threes, more or less.
Let's break them down.
If you get a percutaneous injury with a hollow bore needle from a known positive patient, hepatitis B is by far the most infectious. The risk of transmission is up to 30% if you are a non-responder or unvaccinated.
30%, that's almost 1 in 3.
It's huge, which is why hepatitis B vaccination is mandatory for healthcare workers. If you are an anesthetist and you haven't had your shots and checked your titers, you are being negligent.
Okay, so Hep B is 30%. What about the others?
Hepatitis C is next. The risk is about 3%. And for HIV, the risk is actually the lowest of the three, around 0.3%.
So 33 and 0.3, that's easy to remember.
Exactly. But remember, for Hep C, there is no vaccine. And for HIV, while we have post-exposure prophylaxis, prevention is everything.
And there's another less common one mentioned in the books, herpetic whitlow.
Yes, that's a painful herpes simplex virus infection of the fingertip, usually from contact with a patient's oral secretions during intubation.
So it's less common now.
It's much less common now that universal glove use is the standard. If you see it, it's a sign that someone isn't following standard precautions properly.
Let's talk about biological hazards in the context of aerosols. This has become obviously a massive topic since 2020.
Indeed. The anesthetic relevance here is that we are the absolute experts in the airway, and that means we perform aerosol-generating procedures, or AGPs, all day long.
Intubation, extubation.
Bronchoscopy, suctioning, these all create a fine mist of particles that can hang in the air. We need to understand the physics of it.
What's the key distinction? Droplets versus aerosols.
Yes, the size matters. Large droplets, which are bigger than 5 microns, are heavy. They fall to the ground within about 3 to 6 feet. That's droplet transmission.
And aerosols.
Aerosols are smaller than 5 microns. They're so light that they don't fall, they float. They can stay suspended in the air for hours and travel on air currents through ventilation ducts if they're not filtered out.
And this is why we need N95 masks and negative pressure rooms for certain patients.
Precisely. An N95 respirator is designed to filter 95% of those very small airborne particles. But here is the exam point a lot of people miss. Fit testing.
Right. It has to have a seal.
An N95 mask that doesn't fit properly is just a fancy decoration for your face. If air can leak in around the sides, you are breathing unfiltered room air. It's useless.
And what about protecting the machine and the next patient? The HEPA filter on the circuit.
Crucial. You must place a bacterial viral filter, specifically a HEPA or high-efficiency particulate air filter on the patient side of the Y piece.
Why there specifically?
Because if you put it at the machine end of the inspiratory and expiratory limbs, the entire tubing system becomes contaminated with the patient's expired air. But if you put it right at the Y piece, between the circuit and the mask or endotracheal tube, you protect the entire machine and circuit from the patient's pathogens. It's about protecting the equipment for the next patient.
So wear your gloves, use your filters, get fit tested. Let's talk about chemical hazards now.
Latex allergy is the classic exam topic here. It's a type I hypersensitivity reaction, and it ranges from simple contact dermatitis to full-blown, life-threatening anaphylaxis.
And we're at high risk because of constant glove use.
Exactly. Chronic exposure leads to sensitization. And for your exam, remember the cross-reactivity with certain tropical fruits.
Right, the banana, avocado, kiwi connection.
Yes. If a patient or a colleague tells you they're allergic to bananas, you should have a high index of suspicion for latex allergy.
What about other chemicals? Glutaraldehyde?
It's a high-level disinfectant, often used for sterilizing things like laryngoscope blades or flexible endoscopes. It's very irritating to the respiratory tract and can cause occupational asthma.
Then there's methylmethacrylate bone cement.
The smell of orthopedics.
It's unmistakable.
It is. The fumes from the monomer during mixing can be teratogenic in animal studies, though the human data is more debated.
And in the moment for the patient.
The bigger acute risk is bone cement implantation syndrome. That's the profound hypotension and hypoxia that can happen in the patient when the cement is pressurized into the femur. That's a huge stressor for the anesthetist, but the chemical itself is an irritant to our mucous membranes.
Okay. I want to shift gears now to the one that hit me the hardest when I was reading the source material, Part C, Section 8, Psychological and Mental Health Hazards.
This is, as the outline says, an exam favorite now. And for good reason. It addresses the human factor, which we ignored for far too long.
The specialty is just incredibly high stress.
We deal with life and death situations in seconds, often with incomplete information. The hypervigilance required takes a toll.
The outline mentions the term second victim. What does that mean?
It's a powerful concept. The first victim is the patient who suffers an adverse event or a complication. The second victim is the healthcare provider, the doctor, the nurse, who is traumatized by that event.
The guilt, the anxiety.
The sleeplessness, the replaying of the event in your mind. We often suffer in silence, afraid that talking about it is a sign of weakness.
And this can lead us down a very dark path to the really difficult side of our specialty, substance use disorder or SED.
The statistics here are incredibly sobering. Morgan's textbook states that anesthesiologists have a relative risk for drug-related death of 2.21 compared to internists.
We are more than twice as likely to die from drugs.
Yes.
Why? Is it just the stress?
It's a perfect storm. It's the combination of high stress and, crucially, easy access.
Right.
We have the most potent opioids, fentanyl, sufentanil, remifentanil, and powerful hypnotics like propofol, right in our pockets. Literally, we draw them up every single day. We hold the keys to the narcotics cabinet.
And because we're experts in pharmacology, there's this hubris. We think we can control it. I'll just take a tiny bit to help me sleep.
Precisely. That is the fatal flaw. We think we know the pharmacokinetics, so we can manage a dose for ourselves. But addiction is a brain disease. It bypasses logic.
And the outcomes are often poor.
The source material notes that the relapse rate for opioid addiction in anesthesia providers is tragically high. Miller even suggests that successful long-term recovery often requires leaving the specialty entirely.
Leaving the profession.
Because the temptation of returning to that environment with that easy access is just too great a trigger for relapse.
That is a very heavy point to include in an exam answer, but a necessary one.
It shows you understand the medico-social responsibility of our field. If you are asked about hazards and you don't mention SUD, you are missing the single biggest killer of anesthetists. It's an automatic fail in my book.
Okay. Let's shift gears to Part D, the health effects of all these hazards. We have touched on some, but let's structure it. Short-term versus long-term.
The short-term effects of, say, high levels of waste anesthetic gases in a poorly scavenged room are things like headache, irritability, nausea, and fatigue.
That feeling at the end of a long list in an old theater.
Exactly. You feel exhausted in a way that's more than just the physical work would explain. It's likely a low-level toxic effect on your central nervous system.
And long-term. This is where a lot of the controversy lies, right?
Yeah.
especially around reproductive effects.
This is a critical area where you need to show nuance to the examiner. You can't just give a simple answer. Historically, yes, there was great fear.
What was that based on?
It started with a 1967 Russian study by a researcher named Vaisman. It reported very high rates of spontaneous abortion in female anesthetists. This study scared everyone, and it's what led to the development of the current strict regulations and scavenging systems.
But the science has evolved since then.
Massively. The Miller's Anesthesia 10th edition is very clear on this. Those early studies were deeply flawed.
How so?
There was no scavenging, so exposure levels were enormous. And there was significant recall bias. Women who had suffered a miscarriage were probably more likely to remember and report smelling gas at work.
So what's the current consensus?
The current consensus is that if modern scavenging is used and exposure levels are kept within the NOH limits we discussed, there is no clear evidence of adverse reproductive effects or an increased risk of miscarriage.
So for the exam, state the historical fear, but then clarify the modern evidence-based view.
Exactly. Don't just say anesthesia causes miscarriages. That's wrong and outdated. You should say historical studies suggested a link, which led to the implementation of strict exposure guidelines. Modern evidence, in the presence of effective scavenging, finds no significant association.
That shows depth of knowledge.
It does.
What about long-term organ toxicity? We hear about the liver and kidneys.
Again, these are mostly historical links. Halothane hepatitis was a real thing. We don't use halothane much anymore, but it was an unpredictable immune-mediated liver necrosis.
And for the kidneys, the big topic is sevoflurane and compound A.
Ah, yes, compound A. I see this is listed in the Viva Traps section of our outline, and for good reason.
Let's unpack it. What is it?
Sevoflurane can react with the carbon dioxide absorbent in our circuit, especially old dry soda lime that contains potassium hydroxide, to form a vinyl ether called compound A.
And this compound A is bad.
In rats, yes. In rats, high concentrations of compound A are definitively nephrotoxic. It kills their kidney cells.
But what about in humans?
In humans, despite decades of use in millions of patients, there has never been a proven case of clinical renal failure attributed to it. But for the exam, you must know the biochemistry.
Sevoflurane plus dry soda lime plus heat equals compound A.
Yes, and the prevention is to use fresh gas flows of at least 1 to 2 liters per minute to prevent accumulation, and to use modern absorbents that don't contain strong bases like potassium hydroxide.
We mentioned nitrous oxide earlier just in terms of gas levels, but what about its specific long-term metabolic effects? That's a different mechanism, right?
A very distinct biochemical mechanism that you should know. Nitrous oxide irreversibly oxidizes the cobalt atom at the center of the vitamin B12 molecule.
So it inactivates vitamin B12.
Yes. And by doing so, it inhibits a crucial enzyme called methionine synthase.
Methionine synthase. Why do we need that?
It's critical for DNA synthesis and for the formation of the myelin sheath that insulates our nerves.
Okay, so a lack of it would cause problems.
Chronic, heavy exposure to nitrous oxide, and we see this in recreational abusers or people working in totally unventilated dental offices from the past, can lead to megaloblastic anemia and, more sinisterly, subacute combined degeneration of the spinal cord.
Which presents as what?
Numbness, tingling in the hands and feet, walking difficulties, neurological damage. It essentially mimics the disease pernicious anemia.
Is this a real risk for us in a modern OT?
In a modern OT with effective scavenging, you are very unlikely to get this from occupational exposure alone. But if you have an underlying vitamin B12 deficiency to start with, say you're on a strict vegan diet or have a malabsorption syndrome, and you work in a place with poor scavenging, it's a theoretical risk.
Okay, we have scared the students sufficiently with all the hazards. Let's talk about solutions. Part E, prevention and control.
Yes, this is the positive part of the answer. You need to use the hierarchy of controls. This is standard occupational safety theory, and using the term shows you know what you're talking about.
What's at the top of the hierarchy? The most effective?
Engineering controls. These are the most effective because they physically remove or eliminate the hazard from the environment. You're changing the room, not the person.
The scavenging system is the prime example.
The absolute prime example. Also, high-quality room ventilation. You want at least 15, ideally 20 or more, air changes per hour in a modern operating theater.
Why so many?
Dilution. It's the solution to pollution. You are constantly diluting the waste gases and any airborne bacteria or viruses and removing them from the room. Laminar flow systems also help.
Okay, so after engineering controls, what's next?
Administrative controls. These are changes to the way people work. Policies, procedures, training.
Right.
Work scheduling to prevent excessive fatigue. Policies on pregnancy, allowing staff to opt out of high radiation lists or bone cement cases if they are concerned. And regular training and drills for things like fire safety.
And finally, at the bottom of the hierarchy,
Personal protective equipment, PPE. This is the last line of defense.
you lead aprons, masks, goggles, gloves.
Yes. And it's the least effective because it relies on the individual to use it correctly every single time. You cannot rely on PPE alone if the engineering controls have failed. An N95 mask is of limited use if the room's ventilation system is broken and the air is saturated with viral particles.
I want to go back to ergonomics for a second, under prevention. We listed it in the classification, but we didn't really explain the why or the fix.
That's a fair point. Ergonomics is often dismissed as just common sense, but the physiology behind the injuries is important. Let's think about intubation.
Okay.
The classic sniffing position is great for aligning the airway axis for the patient, but what does it do to the anesthetist?
It forces us to bend our neck and back and lean over.
It creates what's called static loading. When you're holding a mask firmly on a patient's face for 10 minutes during a difficult airway case, your deltoid and trapezius muscles are in a state of sustained tetanic contraction.
That's bad.
It reduces blood flow to the muscle, which causes lactate to accumulate and leads to chronic myalgia and pain.
And the back injuries. It's not just about lifting a heavy patient. It's the physics of the lift, right? The lever arm.
Exactly. If you lift a 50-kilogram patient weight while leaning over the bed, the force on your L5-S1 disc isn't 50 kilograms. Because of the long lever arm of your torso, the actual compressive force on your spine can be 300 or 400 kilograms. That is how discs herniate.
So the intervention isn't just lift with your legs.
No, the intervention is physics.
Yeah.
Reduce the lever arm. Get as close to the patient as possible. Raise the bed height so you aren't bending over. Use slide boards and patient movers so you rely on friction reduction rather than pure lifting.
And you mentioned video laryngoscopes.
Yes. VL isn't just for difficult airways anymore, it's an ergonomic tool.
How so?
A study showed that using a glide scope or a CMAC allows the anesthetist to maintain a neutral upright neck posture, looking at a screen in front of them, compared to the extreme neck extension and bending required for direct laryngoscopy. It saves your neck and back over a career.
That's a fantastic practical point. A video laryngoscope is PPE for your spine.
That's a perfect way to put it.
Okay, let's go deeper into noise. You mentioned it under physical hazards. Is it just an annoyance, or is it a genuine danger?
It is a genuine danger. The average noise level in an operating theater is often between 70 and 80 decibels, with frequent spikes up to 110 or 120 dB from things like orthopedic bone drills or saws.
120 decibels, that's the level of a rock concert.
It is. And chronic exposure at those levels can lead to permanent noise-induced hearing loss. But the more immediate effect is cognitive.
What do you mean?
There is a phenomenon called the Lombard effect. As the background noise level in a room rises, people instinctively start to speak louder to be heard.
Which raises the background noise level even further.
It's a vicious cycle, and it seriously impairs communication. It becomes harder to hear critical alarms, it increases your cognitive load. If you're trying to calculate a complex drug dose and the suction is blaring and music is playing and people are shouting, your error rate goes up.
So a practical step is to turn the music off during induction and emergence.
Absolutely. That is the sterile cockpit rule, which we've borrowed directly from aviation. No non-essential conversation or noise during critical phases of flight, or in our case, during critical phases of anesthesia.
Okay. Part F, medico-legal and ethical aspects. This feels like the section that separates a pass from an honors grade.
It really does. It demonstrates maturity and an understanding of your professional role. You need to be able to mention the regulatory bodies.
Like NEOSH and OSHA.
Yes, NEOSH sets the recommended standards and does the research. OSHA, the Occupational Safety and Health Administration, enforces the laws in the U.S. In India, you would mention NABH guidelines for hospitals, and BRT, the Bhabha Atomic Research Center, guidelines for radiation safety.
And what is the employer's responsibility in all this?
The hospital or institution have a legal duty to provide a safe working environment. That means the scavenging must work. They must provide and maintain TPE. They must provide dosimeters, like TLD badges, to monitor radiation exposure.
And if an injury happens?
They must have clear protocols for post-exposure prophylaxis and reporting, and there are workman's compensation implications if a resident contracts TB or gets a needle stick injury at work.
What about the right to know? I saw that in the notes.
That's part of OSHA's hazard communication standard. It essentially says that you, as an employee, have the right to know what chemicals you are working with.
So the hospital has to tell you what's in the cleaning fluid.
Yes. They must maintain safety data sheets, or SDS, for every chemical in the workplace, from sevoflurane to the floor cleaner, and you must be trained on how to read them.
And what if you do get injured? Say, a needle stick that results in you contracting hepatitis C.
That is a compensable occupational injury, but the documentation is absolutely key. You must report the injury immediately through the proper channels.
Why immediately?
Because if you wait a week, the insurance company or the hospital can argue, how do we know you didn't get it somewhere else? Immediate reporting establishes the clear temporal link to the workplace incident.
Now for the really tough one. What about the ethical duty regarding an impaired colleague? If I see my co-resident diverting fentanyl.
This is a very difficult but a very, very crucial point for a senior trainee to understand. The primary ethical duty is to patient safety, period. You cannot, under any circumstances, allow an impaired doctor to anesthetize a patient.
But it feels like betraying a friend.
Well, I understand that feeling, but you have to reframe it. Reporting them is not ratting them out. It is a life-saving intervention. Left alone, that colleague may die from an overdose.
So you're helping them and protecting patients.
The Miller chapter is very clear on this. Report it to a supervisor or a designated physician health program, not to punish, but to initiate treatment and protect patients. It is the only ethical choice.
Powerful. I want to clarify something we mentioned earlier under physical hazards, electrical safety. Can you explain microshock again for the listener who struggles with physics?
Of course. Macroshock is what we normally think of as an electric shock. You touch a faulty wire, a large current in the milliamps or amps range flows through your skin and your body. It causes burns and can cause cardiac arrest.
Right.
Microshock is different and, in our world, much more insidious.
How so?
Microshock can only happen when you have a direct electrical conduit to the heart, something that bypasses the high resistance of your skin.
Like a central venous pressure line or a pacing wire.
Exactly. A saline-filled CVP catheter is a perfect conductor leading straight to the right atrium.
So a tiny amount of current can be lethal.
Yes. A current as small as 100 microamps, that is 0.1 milliamps, applied directly to the myocardium can induce ventricular fibrillation.
100 microamps. You wouldn't even feel that on your skin.
It is completely imperceptible to the touch, but your heart feels it. This is why all equipment designed for connection to the patient, especially the heart, must be type CF or cardiac floating, which means it has extremely high electrical isolation to prevent these tiny leakage currents.
And this is what the line isolation monitor is for, that alarm that's always going off.
Yes. It's a safety device that constantly monitors the integrity of the operating theater's isolated power supply. It alarms when it detects a first fault to ground, warning you that the system is no longer isolated and a potential shock hazard now exists.
Okay, let's do a quick deep dive into the fire triad. It's a physical hazard, but it involves chemistry and is a true anesthetic emergency.
Essential knowledge. You must be able to state the three components of the fire triad. They are an oxidizer, a fuel, and an ignition source.
And in the OT, the main oxidizer is?
Oxygen, obviously, but also, and this is a key point, nitrous oxide. N2O is not flammable, but it supports combustion just as vigorously as oxygen.
Okay. And the fuel, what's the fuel?
The most common culprit in surgical fires is alcohol-based skin prep, like ChloraPrep. If it's not allowed to dry fully and it pools under the drapes, you get a vapor-rich environment.
And other fuels.
The drapes themselves, gauze swabs, the patient's own hair, and of course the endotracheal tube.
In the ignition source.
Electrosurgery, or diathermy, the Bouvier pencil, is number 1. Lasers are number 2. And a forgotten one is fiber optic light cables. The tip of those cables gets incredibly hot. If you disconnect it from the scope and leave it lying on a drape, it can burn a hole in seconds.
How do we prevent an airway fire specifically? This is the ultimate can't-miss scenario.
You manage the triad. First, reduce the oxidizer. If the surgeon is using diathermy or a laser in or near the airway, you must drop the FiO2 to the lowest safe level, ideally below 30%. And you must stop using nitrous oxide completely. Use an air-oxygen mix.
Okay, that handles the oxidizer. What about the fuel, the tube?
You must use a laser-resistant endotracheal tube. And here's the trick you must mention. Fill the cuff with saline, not air.
Why saline?
Because if the laser beam accidentally hits the cuff and perforates it, the saline will gush out and act as a fire extinguisher, quenching the heat. Air would just feed the fire.
And people add methylene blue dye to the saline.
Yes, so that if the cuff is breached, you immediately see blue dye in the airway, and you know there's a problem before a fire can even start.
And if, despite all this, a fire does happen, what is the drill?
It has to be an instant reflex, a rapid sequence.
1.
Remove the source of the fire. Immediately pull the burning endotracheal tube out of the patient. Do not hesitate. Stop the flow of the oxidizer. Simultaneously turn off all gas flows at the machine.
3.
Extinguish the fire. Pour saline into the patient's airway to put out any remaining embers.
And after that?
Once the fire is out, you mask ventilate the patient with air, then re-intubate with a new tube. And finally, you must perform a bronchoscopy to assess the extent of the thermal and chemical damage to the airway.
That is a life-saving drill. Pull the tube first. I think the instinct might be to try and put the fire out while it's still in.
No, if the tube is the fire, get the fire out of the patient.
Okay, we're approaching the final leg of our session, Part G, exam integration. Let's consolidate all this knowledge for the candidate. How do we present this in the exam hall?
For a written answer, comparison tables are your best friend. They show the examiner you can organize information clearly.
What would the columns be?
Draw a simple table. Column 1, hazard category, for example, chemical. Column 2, specific agent, for WAGs. Column 3, health effect, re-exam headache, reproductive. Column 4, preventative strategy, AG, scavenging. If you fill that out for a few key hazards, the examiner can just tick, tick, tick down the columns. Full marks.
And diagrams.
Absolutely. Practice drawing the scavenging system schematic today. Just a simple block diagram. Also, draw a simple graph for the inverse square law exposure on the y-axis, distance on the x-axis, showing that sharp curving drop. Visuals break up the wall of text and prove you understand the concept, not just the words.
Let's hit some common Viva traps. We've mentioned compound A and the N2O limits.
Yeah.
Are there any others we should be aware of?
Yes. An examiner might ask, is the patient a source of pollution?
For the answer.
The answer is yes. In the PICU, the post-anesthesia care unit or recovery room, the patient is exhaling anesthetic gases for quite a while after the case. That is why the PICU also needs good ventilation with many air changes per hour, a fact that is often overlooked.
Okay, another one. What is the single most effective way to reduce your radiation exposure?
The answer they are looking for is distance. It is more effective and far cheaper than lead shielding. Step back is the correct and smartest answer.
And if they ask for a definition of universal precautions?
Treat every patient as if they are potentially infectious with a blood-borne pathogen. That is the definition. You don't wait for the viral markers to come back. You wear gloves and eye protection for every case, for everyone.
We have a few minutes left to really hammer home the idea of comparison tables. The outline suggests comparing radiation versus lasers. Let's verbalize what that table would look like.
That's a great high-yield contrast table for an exam. Okay, here we go.
Category 1, nature of the energy.
For radiation, it's ionizing electromagnetic waves like X-rays. For lasers, it's non-ionizing, coherent, monochromatic light energy.
Okay, category 2, primary hazard.
Radiation causes DNA mutation, carcinogenesis, and cataracts. Lasers cause immediate thermal damage, retinal burns, skin burns, and airway fire.
Category 3, protection.
Radiation requires lead shielding aprons, thyroid collars, and structural shielding like concrete or lead-lined walls. Lasers require specific wavelength-dependent optical density goggles and using non-reflective matte finish surgical instruments.
And last category, mechanism of injury.
Radiation damages you primarily via scatter from the patient. The laser damages you via direct beam or reflected beam hitting you.
That really clears up the confusion.
Yeah.
One requires heavy lead, the other requires specific colored glasses. And just to be clear, lead aprons do nothing against lasers.
And laser goggles do absolutely nothing to protect you from X-rays.
Perfect. A quick note on infection control. The outline mentions standard precautions. Can you quickly differentiate between standard, contact, droplet, and airborne precautions?
Yes.
Standard.
This is the baseline. Hand hygiene and using gloves or masks whenever you anticipate exposure to body fluids. This applies to every single patient.
Contact.
This is for bugs transmitted by touch, like MRSA or C. difficile. You need a gown and gloves. This is for bugs in large droplets that fall quickly, like influenza or meningitis. You need a standard surgical mask and eye protection.
And airborne.
This is for the tiny particles that float, like TB, measles, or during AGPs on a COVID patient. This requires a fitted N95 respirator and a negative pressure isolation room.
As anesthesiologists, we need to know which one applies the moment we walk into the patient's room.
And often we're the ones who have to enforce it. We have to be the ones to say, stop, this is a TB case. We need to shut the door and ensure negative pressure is on before we proceed. You have to be the safety leader.
Okay, we are at the end of our deep dive. Let's do a final rapid-fire recap of the key numbers for the exam. I'll say the parameter. You give me the numbers.
Let's do it. Ready?
The NaOH limit for nitrous oxide.
25 ppm.
The limit for a volatile agent when used alone.
2 ppm.
And the limit for that volatile agent when used with nitrous oxide.
Torous 0.5 ppm.
The physical law governing radiation safety with distance.
The inverse square law. 1/d squared.
The needlestick transmission risk for hepatitis B in an unvaccinated person.
Up to 30%.
And the needlestick risk for HIV.
Around 0.3%.
The minimum current for microshock to cause VF.
100 microamps.
And the relative risk of drug-related death for anesthesiologists compared to internists.
0.21.
That's the cheat sheet right there. A list of numbers to have on the tip of your tongue.
If you know those numbers, you will ace the objective parts of the exam. If you can explain the why behind them, you will ace the whole thing.
And finally, our provocative thought. We always like to leave the listener with something to chew on.
Here's the thought. We spend our entire careers, every single minute of every case, obsessing over the patient's physiology. We watch their ST segment, their end-tidal CO2, their airway pressure. We are their guardians. But who protects the protector?
The classic, who watches the watchman?
Exactly. The provocative thought for you to take away is that self-care is a patient safety intervention.
Say more about that.
If you are deaf from noise, getting cataracts from radiation, addicted to opioids, or so burnt out from stress that you can't think clearly, you cannot safely care for your patient, you yourself become an occupational hazard.
Wow.
Therefore, looking after yourself, wearing the lead, ensuring the scavenging is on, getting enough sleep, seeking help when you're struggling, is not selfishness. It is the fundamental first step of safe anesthesia practice, as they say on every airplane. Secure your own mask first before assisting others.
That is a mic drop moment. It completely reframes the whole topic. It's not just about a list of rules, it's about your fundamental capacity to care.
It is the truth of our specialty.
To the Gujarat University candidate listening to this, you've got this. Structure your answer, draw the diagrams, quote the numbers, show them you're a consultant in waiting.
And remember, the examiner wants you to pass. They want to see a safe pair of hands. Show them you understand the hazards of your workplace and, more importantly, that you know how to manage them for yourself and your team.
Thank you for listening to this deep dive. We hope this study session helps you ace that exam.
Good luck. Now go draw that scavenging system schematic right now.
Signing off.